Good afternoon. Excellent, thank you. Welcome, and thank you to everyone for joining this important conversation today. I'm Carla Zadnik, Executive Vice President and Provost of the University, but more importantly for today, I'm the Interim Dean of the College of Public Health. The College of Public Health's Changing the Conversation lecture series aims to host thoughtful experts and scholars who inspire attendees, all of you, to think about pressing issues in new ways and ideally to seek opportunities to move our community and nation forward, despite the many challenges that accompany complex policy matters. Today's conversation comes at a critical point in our history, as we're on the cusp of electing a president and living in a time when public health has never been more front and center in national, state, and local policy debates. I am delighted to welcome today's guest and to learn from him. Daniel E. Dawes is a widely respected healthcare and public health leader, health policy expert, educator, and researcher who serves as Senior Vice President of Global Health and founding Dean of the School of Global Health at Meharry Medical College in Nashville, Tennessee. He's the author of two groundbreaking health policy books, 150 Years of ObamaCare and The Political Determinants of Health. Dean Dawes is also an elected member of the National Academy of Medicine and an elected fellow of the New York Academy of Medicine. He serves as an advisor to the White House on health equity initiatives, as an appointed member of the Centers for Disease Control and Prevention's Advisory Committee to the Director, and on the NIH's National Advisory Council for Nursing Research. After his talk, Dean Dawes will be joined by Dr. Lauren Jones, Associate Professor in the John Glenn College of Public Affairs, and Dr. Tasleem Padamsee, Associate Professor in the College of Public Health, for a panel discussion. The moderator of the panel will be our own Stephen F. Loebs Professor in Health Services Management and Policy, Micah Berman, who has a joint appointment in public health and the Moritz College of Law. Please join me in welcoming Daniel Dawes.
Good afternoon, everyone. Good afternoon. I know we can do better than that. I was expecting to get a warm Columbus, Ohio welcome. Good afternoon. Yes, thank you so much. And Dean Zadnik, thank you very much for that generous introduction. And thank you so much for the invitation to join you all today. It is a deep honor to be here and to talk about an issue that is near and dear to my heart, looking at the causes of the disparities and inequities that have plagued us in terms of health status and in healthcare and beyond. And I do want to just take a moment of personal privilege to thank Dr. Maria Gallo, who recommended me to speak. So wherever you are, Dr. Gallo, thank you. And of course, to two very good friends of mine, Professors Micah Berman and Rakaya Yerby, I thank you very much for inspiring me. You've inspired and influenced my work, and for that I'm always appreciative. I also want to take a moment to thank all of you. I know these are very interesting times that we are living in, and I want to share with you why I'm optimistic. Where a lot of folks have become pessimistic or apathetic and have allowed that to really push them into helplessness, I want to hopefully inspire you to think about things a little differently. And I'm not naive, right, to think that these aren't challenging times, but certainly we have the privilege of the era that we're living in, where we can look back at the data and understand the policies that have pushed and pulled us in either a positive or negative direction. So I am trying to find the clicker, and I don't see it anywhere. Did somebody take the clicker? Oh, you have it, okay. Thanks. So here's why I'm optimistic. I think many of us have seen how the hierarchy of human value has evolved over time in this country, how inequities have been structured and concretized in our policies and our programs and processes for hundreds of years. But the good news for all of us is that we've also witnessed the incredible impact that equity-focused policies, such as the 19th Amendment granting women the right to vote, the Voting Rights Act, the Civil Rights Act, the Olmstead decision, or the Americans with Disabilities Act, had on people of color, lower socioeconomic status folks, people with disabilities, older adults, you name it. In fact, research has shown that through the women's suffrage movement, when women got the right to vote, immediately afterwards, we saw large investments in public health. Investments that led to increases in maternal and infant health by up to 15%. We also saw with the Civil Rights Act, Title VI in particular, that many health equity champions fought for, we saw a reduction in deaths. In fact, Nancy Krieger, Dr. Krieger at the Harvard T.H. Chan School of Public Health has actually shown that there were 38,600 Black infant deaths that were prevented by Title VI alone of the law. We've also seen how the Voting Rights Act has absolutely led to improved health outcomes and lifespans among different population groups, especially in rural southern communities. With the Americans with Disabilities Act, for those of you who work with people with disabilities or people with serious mental illness, you know that on average, they tend to die about 25 years earlier than the general population. Well, because of the ADA, what we've noticed after the passage of that landmark disability civil rights law were improvement in health outcomes and, of course, lifespans for these folks. But what happens, though, when there's an attempt to prevent further implementation or enforcement of these egalitarian policies? What happens when you try to repeal these policies? That's when we see a widening of the gap in life expectancy across population groups. It's when we see a downturn in health outcomes among population groups, which is why it's not surprising that we still see so many different people, poor whites, Blacks, Asian Americans, Latinos, Native Americans, and others, older adults, people with disabilities, veterans, struggling to live in a society that has erected barrier after barrier to prevent them from reaching health equity. Many of them have been falling through the cracks of our healthcare system, our mental and behavioral health system, education, transportation, employment, you name it, the list goes on. I want you to let these statistics just wash over you for a moment. We've seen these stats published in over 7,000 peer-reviewed journal articles each year in public health journals, medical, nursing, sociology, you name it, documenting how these under-resourced groups have lived in a society that have intentionally erected these barriers, that have hastened their deaths, weakened their bodies, leading to the striking disparities that we see today in health outcomes. You know, today we know that women spend 25% more time in their lives with debilitating health. Think about that for a moment. 25%. They may live longer, but 25% of that time on this earth is experiencing debilitating health. We know that through research, it has shown that that equates to 75 million years of life lost to this population group. We know that a child, an African-American baby born to a mother, is twice as likely not to reach their first birthday as a child born to other mothers. We know that the list goes on, but you can see it for yourselves. We must do something about it. We also know that since COVID-19, population groups in this country have struggled with life expectancy. 6.6 years lost for Native American, Native Hawaiian, and Alaska Native communities. 4.2 years lost for those who identify as Hispanic Americans or Latinx Americans. 4 years lost for Black Americans. 2.4 years lost for white Americans. And 2.1 years lost for Asian Americans. Right before COVID struck, in 2017, 2018, The Lancet published or had authorized a major global health study. And in that study, they were projecting where countries would be up to 2040. So by 2040, what would be the life expectancy rankings of these countries? And what they found was that the United States, where most countries, similarly situated countries to the US, most developed countries, were expected to add years onto their life expectancy. Here in our country, we were expected to decline 21 places, and we ranked about 43rd at that point. Think about that. By 2040, we were expected to decline to 64th in the world. Today, we rank 60th in the world. And we have 16 more years to go before we were supposed to realize that number. Things are pretty dire. Back in 2009, as we were working on the Affordable Care Act, we had worked with health economists to understand what was the cost of our failure as a country to really address these fundamental causes of disparities among groups. And conservatively, we found that we were spending $300 billion, and that was just on physical health conditions. Dr. Gaskin and Dr. Leviste at Tulane and Johns Hopkins crunched the numbers again and found that in 2018, that number had risen to $451 billion. Well, my group got together and said, you know what, it's not enough to just look at the physical health conditions. What is the cost of our mental health and physical health, right? When you fail to invest the resources to elevate brain health, right, and mental and behavioral health. And so we looked at mental and behavioral health as well as our systemic health, understanding that diseases of the brain impact us systemically and vice versa. What is that cost to society? And we calculated that in this year, we're projecting $477.5 billion, again, owing to these disparities alone. At the rate we're going in 6 years, we expect that number to hit $1 trillion. And by 2040, that's expected to hit $1.3 trillion. That does not include other population groups. We didn't look at differences in sex or gender. We didn't look at disability status. We just looked at racial differences in this country. Something has to be done. What we also found was that when you invest $1 in women's health, it actually leads to a $3 cost savings, return on investment. We found that to be true. Those who have done global mental health studies have found that if you invest $1 in mental health, it leads to almost a $3 return, right? Positive return, 2.6. And the same thing with eliminating racial and ethnic health disparities. So with that, let me turn to the recent headlines. Many of us have seen these headlines highlighting the everyday impact of the political determinants of health, the effects of which can be observed in many areas of health and healthcare, including young children growing up without mothers owing to high maternal mortality rates, or poor and lower socioeconomic status families being funneled into substandard housing by inequitable systems. For those of you who work in the mental health arena, you have seen probably the recent research showing that people with depression, anxiety, PTSD, bipolar disorder, drug or alcohol use disorder, ADHD report over twice the odds of being able to access transportation in their communities. We've also seen over the last several years the struggle to advance health equity in America and the levers of policy and politics that have been used at all levels and by all branches of government, which have affected the health outcomes of virtually every single population group in one way or another. I want to quote Thomas Piketty. For those of you who follow this world-renowned economist, for decades he has studied inequality in the world. And recently, he concluded that inequality did not simply emerge from economic reality, from technological change, or the organization of production, nor from inherent disparities in individual talent, ability, or effort. Rather, he states, inequality is determined through struggles that take place in the political sphere. Think about that for a moment. Inequality is determined through struggles that take place in the political sphere. So this raises an important point. If the resources and the advantages attained through the political sphere are not equally distributed among population groups, then it's not surprising that health outcomes and premature deaths are not equally experienced among certain population groups. Let me be very clear today. Health inequities are the unfair and avoidable differences in health status that arise from the social conditions in which all of us are born into, we live in, we pray in, we work in, and we age in. And this is caused by no fault of their own. These differences are not merely about genetics or individual choices. They are instead deeply rooted in social structures and policies. Health equity seeks to address these challenges by ensuring that everyone has a fair shot to be as healthy as they possibly can. And fundamental to this work is the core truth that these differences can be reduced or even eliminated by taking proper action and, of course, investments. And this is the important and the essential distinction that the political determinants of health makes. You see, in the United States, our community's health is not an organic outcome. It's not a coincidence that certain groups of people in our community experience higher premature death rates than others. It wasn't a fluke that some groups experienced poverty for generations, blocked from attaining the American dream. You see, our system has not always valued each group equally or realized the long-term implications that policies have on the health of its people. Why is this happening? Why has it been happening? Well, today we recognize that there are a variety of forces collectively impacting our health and determining the quality and the extent of our lives on this earth. And they, of course, include the social determinants of health, behavioral health, clinical care, physical environment, genes, biology. And key among the determinants, it is argued, are the social determinants of health, the structural conditions in which all of us, again, are born into, we live in, and we eventually die in, that affect all aspects of our health and well-being. And of course, they do play an outsized role in our overall health and in the human-made pre-existing inequities. But underlying every single one of these social determinants of health, whether it is housing-related, education, transportation, food security, you name it, was a political determinant that we can no longer ignore. See, for too long in public health and beyond, we've been stopping at the social drivers of inequities, failing to look back and just dig a little bit deeper to understand the root causes and its distribution. And as a result, we've been failing to make the link between these social determinants, these healthcare determinants, and their policy roots. You see, for every single social determinant of health, there was a preceding law, an ordinance at the local level, statute, case law, a policy that resulted in the structural conditions in which we all find ourselves in today. For those of you who work with patients or who work with communities that have struggled, it's really important that you understand how this has worked. Sir Michael Marmot, out of London, a physician, primary care doctor, spent years providing the best healthcare that he possibly could to his patients. And he was just struggling with, why is it that I'm giving the best medication, I'm giving the best advice, medical advice, and yet they're still struggling with diabetes, heart disease, high blood pressure. They can't control it. And one day he decided to follow his patients, to see where they live, to go out into their communities. And that's when it struck him. My goodness, there are these situations that folks are dealing with in their community, right? Whether inside their homes or immediately outside of their homes, that do have an impact on their health. So this begs another question for us in the United States. How did we get here? How did we get to these striking inequities in health status and healthcare? How is it that inequality gets under our skins, leading to accelerated aging in our bodies, as Dr. Arlene Geronimus at the University of Michigan has studied? How is it that it actually leads to the earlier onset of diseases, diabetes, heart disease, cancer, in certain communities? as Dr. David Williams has studied? Well, we know that the impact of slavery has been associated with contemporary mortality, poverty, heart disease, intergenerational trauma, maternal and infant mortality. And I want you to think about, as you're thinking about the structural conditions that you operate in or you live in, I think it's so important that we think about how they came to be in the first place. It wasn't by accident. So, I want to start looking at big P, little p policy, both governmental and non-governmental policy, and I want to take us back 400 years. And I'm doing that because this was the point where you could see the commercial interests working with the policymakers to develop policies that would restrict the rights of certain groups. I'm not going to start at 1619, although I do believe that is a fair starting point, but I'll start at 1641. This was the time when the commercial interest worked with the policymakers to devise the Body of Liberties law, a law that was designed to push back on the abolitionists who were fighting to ensure that they would be able to free the enslaved folks at the time. Well, they succeeded in Massachusetts. They used that as a template for the other colonies. They got that developed to the point where folks said, good, we have codified this institution into law. We're all set. The abolitionists came back and said, wait a second, upon reading the law, we don't believe you intended to include the offspring of black enslaved folks. And so the commercial interest and the policymakers got back and said, wait a second, we did mean to include them. Let's make that more explicit. They amended the law so that it would include, for purposes of the law, it would be very clear that these individuals for generations would be deemed slaves as the law required. Well, as if that weren't enough, after that effort in the later 1600s, we then saw an attempt to restrict, to develop policies that prohibited black and indigenous population groups from being able to raise their own food. We know that food security, access to nutritious foods, is a major social determinant of health, and yet by an act of policy, they were forbidden from doing so. We know that additional laws were developed that, again, prohibited these groups from being able to be educated, from learning to read and write. We know education is a major social determinant of health, and actually, we know that there's a strong correlation in your life expectancy and your educational levels. In addition to that, laws were also developed that prohibited black and indigenous groups from being able to earn their own money. We know employment is another critical social determinant of health. And so you can see how policy authorized those results in the end. Moving fast forward, we went from the 1600s into the 1700s and into the 1800s, where Jim Crow reared its ugly head with a vengeance. And the forces of ill will, as Dr. Martin Luther King Jr. called them, were adamant, right, that they had to institute policies at local, state, and federal levels that again denied black and brown groups, poor whites and others to an extent, but mostly African American groups, an opportunity to exercise their civil rights and address their social determinants of health needs. We move from the 1800s into the early 1900s. And at this point, this is really interesting. This is where you can see how racists are very clever people, utilizing policy as a tool of oppression. In this case, we went from what we call explicitly racist policies in the law to what we call facially neutral policies. So on their face, they do not discriminate against one group or another, but they are designed and crafted in such a way that they will have the same impact when they are implemented and enforced. The Social Security Act was one such law. The Surgeon General at that time, Dr. Perrin, basically the architect, for those of you who know about the Tuskegee syphilis studies and the Guatemala prisoner experiments, syphilis experiments, he was the architect behind those horrendous public health acts. And he worked with lawmakers to develop the Social Security Act so that it would not include certain population groups, so that these groups wouldn't realize the social and economic benefits that the policy was providing. In this case, these were agricultural workers, domestic workers, where 78% of African Americans fell into one of those two buckets. And in addition to that, this included immigrant groups at the time, largely your Italian, German, Jewish, and other communities. And interestingly, that was allowed to be implemented as such. We know, fast forward, for many of you who, again, work in communities, you may have noticed this 41,000-mile interstate highway that cuts neighborhoods in half. As I've spoken to members of communities that are impacted by that infrastructure, and I asked them, how did this originate? Folks look at me confused. I don't know. And for those who have been on the earth a little bit longer, older adults have said to me, I remember when I was a little girl, and we had a home right there where, the highway is now. And I remember my parents getting a notice that they had to move, that we had to move. That's the Highway Act that created the infrastructure. Today, through public health research, we know that those who live closer to these infrastructure have higher rates of asthma. We see the highest rates of asthma among lower socioeconomic status individuals, again, who live closer, the high particulate matter that they have to breathe in every day. We have also seen higher rates of diabetes, right? Again, because the infrastructure closed off opportunities, walkways, and whatnot for them to get access to the green and blue spaces that so many of us enjoy. In addition to that, we saw the Housing Act, a law, again, at the federal level that was implemented at the state and local level that was designed to affect the lives of lower socioeconomic status individuals, essentially authorizing the displacement of over 500,000 people across the country. Today, through data, we can see the health impacts that policy has on these groups. The Homeowners Loan Corporation Act. Let me stop with that one and go on. But many of you may have heard about the term redlining, and through this Homeowners Loan Corporation Act, the federal government, essentially trying to stimulate the economy, worked with state and local policymakers to allow property appraisers to go out in the communities, over 200 neighborhoods across the country, and to color code them appropriately and to assign them a grade, A, B, C, or D. Your C and D communities, these are your yellow-lined and red-lined communities. These were your largely immigrant population groups, again, at that time, German, Jewish, Irish, Italian, Mexican, Central American, and a few others. And then the red-line communities were your predominantly African-American communities. These were declared hazardous communities. So what the federal government did was not only create an act to authorize the development of these reports nationally, but once the reports were done, they were then sent back to DC, where the federal government analyzed that data and used it to develop additional policies, determining which groups would be able to access home mortgage loans, VA and FHA home mortgage loans. For the sake of time, you can see the impact that these policies have today in communities across the country in the form of a poverty tax, where they have to pay higher payments for auto insurance and home mortgage loans. They get lower property appraisals. You can see how this has led to deserts in these communities, food, pharmacy, and hospital deserts. And interestingly enough, where the federal government refused to invest in certain, or state and local governments refused to invest resources in certain communities, the commercial interests, the little p, came in and said, well, if the government isn't going to invest in these communities, neither are we. That would be a poor return on our investment, they argue. And you wonder why we see how difficult it has been for many of these communities to access resources to improve their health and maintain their health. We know that political determinants of health are evidenced in the data. Research has shown that high obesity rates, maternal mortality, gun violence, depression, opioid addiction, substance use disorders, diabetes, heart disease, cancer, HIV/AIDS, and many other health problems can be firmly linked back to political action or inaction. You see, policy is a driving force for many of the health challenges that we have seen or you may have even experienced yourselves. But it can also be a driving force for achieving health equity in communities you work in or you seek to work in. Because only policy can fix what policy broke in the first place. Think about that. I want to take us back one more time in the past. The great Southern writer William Faulkner says, the past is never dead. It's not even past. And how true is that as we've gone through the last several years? You know, throughout our history, you can see the constant struggle, a tug of war, if you will, between those advancing the political determinants of health inequities and those that have been working overtime to counter the negative effects of policies by leveraging the political determinants of health. So I want to take us back one more time because I've had folks challenge me and say, Daniel, it's not fair. You started at 1641. We weren't even a constitutional republic then. That's not fair. I said, fine. Let's start at 1789. So permit me, please, to take you back one more time to 1789, because this was when you had folks who were champions for the homeless population, advocates for homeless people, mental health reformers, abolitionists, and others who were fighting for the least among us, coming together, saying, what can we do to get our federal government to provide for the general welfare of its people? And as they were strategizing, they thought long and hard about how to proceed, and they said, you know what? We need a major policy influencer. Why don't we ask Benjamin Franklin to come and lend his name to this effort? And they crafted a petition. The petition essentially called for the federal government to stop the separation of children from their mothers, to stop the breakup of enslaved families, to stop this horrible institution once and for all. It also called for the federal government to provide health-sustaining and health-protective resources to poor whites, to homeless individuals, to people who are suffering from mental illness in our society. Again, to provide the necessities that they need to thrive, or not only survive, but thrive in our communities. Well, Benjamin Franklin thought long and hard, and he says, you know what, I will lend my name to this petition. And signed the petition. It was then delivered to the House and the Senate. And if you think that we're having a very contentious debate over stretching the umbrella of inclusivity and equity in our society, it seems to me from the records that it was equally as contentious, if not more contentious. Folks in the Senate said, how dare you, Benjamin? How dare you, health equity champions, essentially, bring up this issue when you know that we're just getting settled as a country? Now is not the time to be bringing up this issue of wanting to provide resources, healthcare access, to eliminate disparities among groups. Now is not the time. Isn't that a refrain we continue to hear even until today? Now is not the time to stretch that umbrella. Well, the Senate said, we're not even going to dignify Benjamin Franklin's petition with an answer. But the House said, we cannot let Benjamin get away with this. And so, in bullet-by-bullet format, they made their confederalism argument, arguing essentially that the states are closer to these enslaved folks and poor folks and people with disabilities. Therefore, they know what's in the best interests of these people. They essentially punted the opportunity to abolish slavery and to provide health-protective, health-sustaining resources to people. Benjamin Franklin gets that response. But unfortunately, as we know from history, he died right before he could respond, 3 weeks after he had sent the original petition. That is the first time in our history, nation's history, that the light of health equity had dimmed for us in the movement to advance health equity. It would take 75 years later, this time under the administration of Abraham Lincoln, for folks to fight for the same policy priorities again. Think about that, 75 years later, as we're going through a major civil war. President Lincoln, he knew that once the war was done, we would have thousands, hundreds of thousands of newly freed people and poor whites who would be displaced as a result of the war. He knew that we needed to provide health care, right? Access, that we need to provide food and clothing and educational opportunities and even employment. They even provided security, in fact, from the Freedmen's Bureau Act. But there was one provision that was still too contentious for even his supporters to embrace. And that was the provision to provide health care services to these folks, to the least among us. Does that sound familiar? Is it any wonder we've had the debate over Obamacare that we had? It's not surprising when you go back 150 years and you see the same arguments being made. So, President Lincoln says, in the spirit of compromise, as the war was winding down, please get this bill done, strike the provision to provide health care, leave everything else intact, get it to my desk, and I will sign it into law. And that's essentially what he did. He signs it into law, and as we know from history, unfortunately, he was assassinated 4 weeks later. His supporters, looking at the crisis, said, you know what, we cannot squander this crisis. And so they worked and they looked at the law and they said, you know what, upon rereading this statute, we believe that it does authorize us to provide healthcare services to these newly freed people and poor whites across the country. And so they went about immediately recruiting clinicians from the North into the South and Midwest. They started building sanitariums or hospitals and clinics across the country through the Freedmen's Bureau. And they, of course, provided other human services resources. Well, I think what we've also seen over the last 4 years is something that is also true in our country, that hate never takes a break, and racism doesn't sleep in this country. And that's exactly what happened with that program. The forces of ill will were determined to dismantle the program, and they succeeded 7 years after in dismantling the first major, most comprehensive and reticulated health program in the United States. It would take us 150 years after that, under the Obama administration, for us to be given another opportunity to create a comprehensive and reticulated health policy, the Affordable Care Act, that actually, even more than the Civil Rights Act, brought people with disabilities, brought older adults, brought LGBTQ individuals, brought racial and ethnic minorities, children's groups, women's groups, and others together under that North Star of health equity to craft a policy that would positively benefit their respective population groups. Before anybody says, my gosh, he's so depressing, Dr. Zadnik, why did you bring him over here? If you're doing the math, you're like 75 years, 150 years, what, it's gonna be 300 years later before we see any real change? No, and here is why now. So I'm gonna get a little more positive with you all. You know, Doctors Hall and Graffunder and others have published a lot on various interventions, and they have concluded that downstream interventions which focus on change at the individual level are more likely to increase health inequality than our upstream interventions which focus on social change or policy change. The National Academy of Medicine, many of you may recall, maybe perhaps you have studied this in your classes, 20 years ago, the Institute of Medicine, as it was called back then, released a groundbreaking study called Unequal Treatment. It had highlighted striking disparities in healthcare that opened the minds of clinicians and public health workers across the country. People were horrified by the evidence. The National Institutes of Health said 20 years later, we need to look, it's been 20 years, where are we in terms of interventions that have been created to mitigate inequities in healthcare and health status? And they asked me and my team to look at the data. We went into the data, and what we concluded was that the majority of interventions had been ineffective because they had never designed them with the community, right? So the communities that they were designed for never helped design it. They had no ownership interest in the interventions. Many of them failed to recognize that a one-size-fits-all approach does not work when we have diverse community members with various lived experiences and cultural beliefs and so forth. And they also fail to recognize that it is really important that you bridge the clinical interventions to a structural or policy level interventions. The ones that have realized that in healthcare have been the ones that have been most successful and seen tremendous improvements in their communities. So with that in mind, let's talk about political determinants of health. So I define the political determinants of health as involving the systematic process of structuring relationships, distributing resources, and administering power. Interestingly enough, in our country, we know that the principal roots of historical as well as contemporary health inequities are found in these political determinants of health, which have inequitably distributed social, medical, and other determinants. And they're the ones that have created these structural barriers for population groups in our society. All political determinants of health affect every single one of us in the sound of my voice. Again, think about that for a moment. Let's look at how we can leverage this. So, whenever I'm analyzing a health outcome, whether it is an inequity or not, I think about them in terms of how they came to be in the first place. What was the policy that created it or has been perpetuating or exacerbating that health outcome? How did policy or political action or inaction structure relationships in the community? How have health protective and health sustaining resources been distributed in that community? And how has power been administered over time? Once that analysis is done, I then turn my attention to the Political Determinants of Health framework. So as you can see from your screen, this is my attempt at showing you some of the laws and how we have analyzed them to understand, as we've worked in communities, to get a sense of how this has worked, right? In this tripartite, this three buckets, if you will, oftentimes cross-cutting one another. You get a sense of how they've worked from the front end on that continuum to the back end. According to the National Academies of Medicine, mortality is affected by factors operating at that macro-structural level. These are your state policies or corporations. Also at the meso level, the workplace level, and the individual or the proximal level. These are your health behaviors, socioeconomic circumstances. And according to the National Academy of Medicine, the macro-structural level exerts a strong influence on all of the other levels, that midstream and downstream level. So for instance, as you're thinking about this, state policies affect individuals' access to affordable health insurance. State policies can influence health behaviors through tobacco excise taxes, marijuana legalization, alcohol pricing, opioid prescribing, and more. And of course, state policies can influence individuals' socioeconomic circumstances through education expenditures, minimum wage levels, housing, policy, taxes, and much more. You see, when the current health inequity challenges are viewed through the political determinants of health lens, tangible and meaningful steps that are within the scope of human control, all of our control, emerge. Actions that can be taken to better, more equitably, and justly protect and preserve the health and the well-being of everyone. That statement, though, while it is true, is not meant to suggest that it is an easy or straightforward path forward. However, the Political Determinants of Health framework encompasses myriad points of influence within and throughout the social, economic, and political systems. So for instance, voting, advocacy, commercial interests, government, policy, all of them operating independently and in tandem exert positive or negative pressures on all individuals and communities. This complexity in our system, in our society, demands that the political determinants of health be considered in everything that is conceptualized, planned, organized, implemented to more meaningfully reduce and hopefully one day eliminate the health and healthcare disparities in the nation today. I want to share with you as an example of how this has worked. For those of you who are my mental health champions, any mental health champions, behavioral health champions in the audience? Just a few? Okay, that's more than, all right, that's good, I'll take that. I remember when I first asked audiences, only one person, if they were brave, would raise that. But we've got to fight the stigma, you all. So let me go back now one more time. This is to the 1940s, because the mental health champions, mental health reformers tried so hard to get the federal government to pass policies that would address the mental health needs of people who are either physically or mentally dealing with struggles, right? And in this case, Dorothea Dix, back in the early 1800s, had been going around. She was a teacher and a champion for people with mental illness. She had gone around the country documenting the abuses against people with mental illness. At the time, if you had a mental illness, my goodness, they would pick you up from the streets, they would take you to the jails, they would chain them oftentimes to the jail walls, they would strip them naked, they would beat them. They tortured these folks. It was absolutely horrible. And what Dorothea Dix did was to go from state to state highlighting the abuses. She thought that she could make the moral argument that these people are being abused, that they are suffering. And she thought that would be convincing to policymakers at the time. Well, she quickly learned, after 4 decades of her life fighting for people with mental illness in this country, she very quickly learned that that was insufficient. Unfortunately, it would take 100 years after that, as we were going through World War I and World War II, for the mental health champions to say, my goodness, we have been making this moral argument, and it hasn't resonated. And you can make the moral argument, and I know that this is a contentious issue with folks who have read my book. You can make it till your tongue bleeds. And oftentimes governments, not only in the United States, but around the world, have ignored it, right? What the mental health champions recognized, working in concert with military leaders and generals in the 1940s, working with business leaders at that time, was that they had to make an economic and national security argument. What they did, working with these military leaders, was to say, how in the world, if you do not give us resources for our communities that are struggling with mental illness, how in the world can you expect them to outcompete our global competitors or to defend the nation from external threats? Finally, the government said, oh, okay, when you put it that way, we will create this legislation around mental health. And finally, they were able to get a law passed in 1946 that created the National Institute on Mental Health to study mental illness, diseases of the brain. And of course, after that, successive presidents, both Democrat and Republican, understood how, on the hierarchy of value that we place on chronic diseases, how mental illness can affect us systemically, and they were willing to pony up the resources. Well, we learned back in 2009 very quickly, as we were making the argument, that 100,000 people almost are dying each year because they can't access healthcare in this country, because they have lower quality healthcare, because they're not getting the public health resources that they need. And we made that moral argument, and even under the Obama administration, folks ignored us. It wasn't till we got with retired military leaders and generals and our health economists, and we started crunching the numbers to understand the projection of costs. And folks said, whoa, now today, in the 1940s, 25% of young people were unfit to serve in the military. 40% ended up leaving the military prematurely, and 60% of the hospital beds were being occupied by people with mental illness. Fast forward to 2009, as we were working to convince the Obama administration to push for comprehensive and reticulated health reform in America, we shared our findings that 75% of young people today, or at least in 2009, were unfit to serve in the military, owing to higher rates of obesity, higher criminalization records, higher rates of mental illness, opioid addiction, and so forth, that were impairing their ability to proceed. So, as you are moving forward, here are some essential political determinants of health questions to ask yourselves as you are developing interventions to mitigate the impact of health inequities in the community, as you're working to improve health outcomes. For the sake of time, I've been given the signal that I need to close, but you have that there, and let me just close with this. Where do we go from here? Where do we go from here? I've been talking a lot about the executive and the legislative branch of our government, but there has been that sleepy branch of government that has awakened as of late, that has been overturning precedent. I want to talk very quickly about the Supreme Court, because in recent dicta, in many notable recent case law, we know that they have significant implications for the health outcomes of our community. You know, the Supreme Court has acknowledged ongoing structural and institutional discrimination, but here's what they've said in dicta. Vestiges of past segregation by state decree do remain in our society. Past wrongs committed by the state and in its name are a stubborn fact of history, and stubborn facts of history linger and persist. But, they argue, though we cannot escape our history, neither must we overstate its consequences in fixing legal responsibilities. Why is that alarming? It's alarming for at least 3 reasons that I could come up with, and I know we have more brilliant folks in the audience who could add to this list. But first, the court fails to take into account the evidence from a broad spectrum in research, from public health, nursing, medicine, science, allied health, sociology, anthropology, psychology, you name it, demonstrating the lasting impact that these vestiges of slavery, segregation, and subsequent unjustified discrimination have on population groups. Second, it has a rippling effect, setting a precedent for other policies that are commissioned by other governmental bodies at all levels. And third, the court has arbitrarily been determining the point at which these vestiges of legally sanctioned discrimination cease to significantly impact certain communities, essentially arguing that after a certain amount of time, it doesn't matter anymore. Get over it, the court says. Well, here's why we can't get over it, and why, as future health leaders and clinicians, as current scholars in this realm, it is so important that we think about them in its complete context, right, in its entirety. Why we have to connect the social determinants of health to their policy roots. You see, the court would rather view inequities as products of, quote, private choices, or products of the social determinants, so they don't have constitutional implications or legally enforceable remedies. Health equity champions who continue to make the case that inequities are solely socially derived and fail to show the policy or the political connection will only bolster the Supreme Court's viewpoint, thus weakening legal protections to check these structural and these institutional forms. Let me now close for real with this last thought, because again, I don't want to leave anyone depressed, but I want to inspire and I hope to motivate you, because what I would like to argue for, my charge today, is really one where I'm asking you to think about how we might be able to reshape, reform, and modernize our approach to addressing these inequalities in our society, to make sure that we can place the U.S. among the healthiest nations on earth, to move from 60 to at least the top 5 in the world. We can do that. We know that through the Global Health Security Index, America is struggling with our public health. We are gone down to 45th in the world. We are also today, out of 195 countries, at 183rd for healthcare access. A country that spends more than half the world's resources on healthcare. We consume more than half of the world's resources. And yet, we are not even among the healthiest nations on earth. Think about that. So let me remind you and tell you again why I'm optimistic. Because the way that I have sliced and diced history, when I look back through the privilege of time that we have today and looking at the data, we've gone through 4 health equity awakenings. The first one occurred under President Abraham Lincoln when he boldly abolished slavery in the country. And he pushed for a law that would provide health protective and health sustaining resources that would address the social determinants of health needs of poor whites and newly freed blacks. The second awakening happened about 100 years after that. about 2 years into the civil rights movement, when Dr. King realized that of all the forms of inequality, injustice in healthcare is the most shocking and inhuman, he argued. And health equity leaders said, my God, he's right. We have to address the overt forms of discrimination in healthcare. We've got to eliminate segregated healthcare and integrate our health system. And they worked on that. But then afterwards, folks realized, wait, we address the overt forms of discrimination, and yet we still see these disparities in health status and healthcare. What is going on? We got to address that too. And so there was an attempt on a bipartisan basis, both Republican and Democrat, working together to address disparities in health status. We had piecemeal attempts to address the issue. And now we find ourselves in the fourth period, where folks have said, okay, we've talked about disparities, but today we recognize what the causes, the fundamental drivers of these inequalities are in our society. We've got to get to the root causes, as Dr. King implored us 60 years ago. Today, we have governments at all levels, local, state, and even today federal, that are allowing us to center health equity to a degree that I really didn't dream was possible in my lifetime. And we have a government that is prioritizing investments, looking upstream at those drivers that have been keeping us from becoming among the healthiest nations. That's exciting to me. We now have an opportunity to get to the root causes once and for all. In order to do that, I want to leave you with my last quote, a last thought from a dear friend and mentor, Dr. David Satcher, who served as this nation's Surgeon General, the 16th Surgeon General, a man who dedicated his life to ensuring that every single person living in our country would be able to realize a more healthy, equitable, and inclusive tomorrow. Dr. Satcher says, Daniel, what we need now more than ever are leaders who care enough, know enough, have the courage to do enough, and who will persevere until the job is done. First, you have to care about every community. Doesn't matter their political persuasion, their backgrounds, their racial and ethnic backgrounds, their socioeconomic status. You have to care about every single one of God's children. But as you have also heard, caring is not enough, right, in this movement. You have to know enough. You have to avail yourselves of the knowledge of these political determinants of health. You've also heard today that this is not a movement for the faint of heart. It does take tremendous courage. And as you can see, it takes a lot of patience, but also perseverance in order to continue to push back on that pendulum from unraveling the gains that we have made in this movement. I hope that we have such leaders in this audience today who will commit themselves to fighting for health equity for all groups. Thank you again so much, and thank you, Dean, for the opportunity to speak. And now I'm going to ask Professor Berman and our panel to join us on the stage.
Thank you so much, Professor Dawes, for your words. I wrote down, only policy can fix what policy broke, and I feel like that's what I'm shouting from the rooftops all the time, but I've never said it as succinctly and as eloquently as you did. So I appreciate that. I really appreciate you sharing your insights with us today. I'm Micah Berman. I'm the Stephen F. Loebs Professor in Health Services Management and Policy at the College of Public Health and a professor at the College of Law, and I am pleased to be joined by my colleagues, Dr. Lauren Jones, Dr. Tasleem Padamsee, to continue this conversation. And we will talk for a little bit and then ask for audience questions as well. So first, would just like Dr. Jones first, and then Dr. Padamsee to introduce themselves.
Thank you, and thank you, Dr. Dawes, for that wonderful talk. It was very informative. I'm Lauren Jones. I'm an associate professor in the Glenn College of Public Affairs, and I do research I'm a quantitative scholar. I'm a policy analyst, and I do research on tax policy, health policy, and social policy. And I'm mostly interested in children and low-income families.
Hi, everybody, and thank you for the opportunity to be here and participate in the conversation. I am Tasleem Padamsee. I am an associate professor in the Division of Health Services Management and Policy in the College of Public Health, and a sociologist by training. And I do research at the intersection of social inequality and health policy. I have two kind of long-term projects that have dominated a lot of my work. One is about HIV and AIDS policy in international contexts from the beginning of the epidemic until today. And the other has to do with breast cancer prevention, particularly in high-risk populations and marginalized groups in the United States. In 2020, I was also involved in the COVID-19 response in Ohio with the Ohio Department of Health, particularly focusing on that response for marginalized communities and minoritized people. And then after that, the vaccine equity and access efforts here through OSU. And I also have the pleasure of teaching our PhD students in their advanced health policy seminar, where we talk about all kinds of policy challenges and get frustrated on a regular basis. So this is a good conversation for all of us.
So speaking of getting frustrated, we were promised some optimism. And Professor Dawes, you started with optimism and then, I think gave a realistic view of the many, many challenges that we face in pursuing health equity. And I sit in public health, and I think a lot of students come into public health because they want to change policy and because they believe in the importance of basing policies on evidence and the power of evidence to influence policy. But we can see from history that there is not at all a straight line between evidence and policy. So I want to ask, starting with Dr. Padamsee, how do you think about the connection between your work and the evidence generation that you're doing, and how you see or hope that it will ultimately connect to policy change?
Yeah, great question. So I think, first of all, we do have to recognize, as you've so convincingly stated, the importance of politics and policy decisions on our ability to advance health equity, and also on the ways in which health equity gets debilitated. And also the fact that those political decisions constitute our purposeful societal decisions about where we want our health outcomes to go, what our priorities are, and what we believe in. So the stakes are very high. And from that perspective, I think we can't do anything except try to be optimistic and try to make attempts to make our research influence policy in whatever ways that we can. We also need to be realistic enough to understand that there are barriers around every corner to that attempt, and strategic enough to figure out how to get around them. And hopefully we do that by encouraging each other not to give up on that effort over time. So with that in mind, I think we can think about the policy impact of our work in big ways and in more focused strategic ways. I think in the big ways, a lot of us imagine that we are going, or hope that we will influence, say, the key legislators who are working on an issue in our state or at the federal level, that those people will come to us and say, hey, you're the scientific expert on this, give us some information. Or that if we go to them and say, hey, I have the science on this, they will want to listen. And some of us, in fact, do have that kind of impact, and a lot of times that is the result of cultivating the right networks and the right entry points for a long time in order to get there. But there's other more focused ways that a lot of public health researchers have impact on policy over time as well, through more standard roles as scientific experts. And those things happen when, for instance, we serve on advisory committees. And those advisory committees can happen locally, they can be at the state level, they can happen with our policy advocacy organizations. And those are the places where we get to sit in rooms and talk about what the evidence is, package that evidence in ways that policymakers can hear into the sites where policymakers are already looking to get the information and hopefully to use it. And then there are other aspects of that scientific role, I think, that come more informally, often just because we're doing the work and we're sticking with that work and we get asked to do it. And that's about walking through the door when it opens. So as an example that happened to me recently, the U.S. Preventive Services Task Force writes these reports where they summarize evidence on an issue. And they ask people to write those reports reports, they ask people to comment on those reports, and they use our science in making those reports. And when you walk through those doors and say yes to those invitations, you're contributing to reports that then shape what insurance plans are required to cover and what they're not required to cover in the way of preventive health care for the rest of us. So that's a direct policymaking influence that is not the kind of thing we think about when we think about, I want my science to drive policy, but I think it's critical, and it's a way a lot of us can contribute. And I'll just say one last thing, which is that I think international context is also important. And unfortunately, there's a body of evidence that tells us that in the US, we face far more barriers in far more places to having our science influence policy in health and in many other areas as well. And that is a result of political institutions and also repeated policy decisions over time. And I think it would behoove us to look to international contexts as we imagine futures in which we might shape different ways of allowing science to influence policy and making sure that it can.
I think that's just such a great answer. I'll just add that I think we in academia can do more to ensure that happens. And I think two examples that come to mind immediately for me are firstly the fact that we are not trained as researchers and academics to communicate to audiences outside of our disciplinary bubbles for the most part. Some of the students in the audience may be surprised to hear that they don't actually teach us how to teach. And I think that deficit really plays an important role in our ability to have our policy messages get through in a way that is compelling. Professor Dawes, told that great story about the advocate who was, making the moral case over and over and over. And I think many of us in the fields, in the health field and other fields that are focused on reducing inequities really kind of find the truths that we work with self-evident. And I think, we really need to find a way to get out of that mindset and to find the ways to make the messages compelling to our students, to the policy community more broadly, and to our legislators. The other thing I'll add is I think that academia really has an incentive problem. I don't think that we are set up in such a way to incentivize researchers to do the type of work that you were mentioning. So, this idea of going out and making relationships with, let's say, government agencies or other change makers, conducting research that is, where the research questions are driven by government. Those types of work are not incentivized in traditional academic spaces. And I think as an institution, OSU, and as the institution of academia more broadly, we can really kind of make some progress on that front to make it easier for researchers to be conducting this kind of different type of engaged research where the engagement is really happening with policymakers.
Thank you. So I'll add from a recent story. I don't know how many of you work with CMS, Centers for Medicare and Medicaid Services, but the administrator of CMS and I spoke last week, and she was sharing with me that she always looks to Health Affairs, the American Journal of Public Health, and other journals to see where she can get the evidence that she needs to push whatever models or interventions that the centers is thinking about. Or there may be a concept that they're considering, and they're very interested in seeing what has been published. So they do a lit review to figure out what has been stated on this, what would work, what approach should we adopt as an agency. So I think that matters. She talked about thought leadership is really important outside of publishing and peer-reviewed journals. Getting your op-eds out there and getting it into these newspapers, the evidence, right, into more mainstream media, so that when they are going through their phones in the morning and looking through the newsreel, something may pop up and catch their attention. So that matters. And even from a personal standpoint, having worked in the House and in the Senate, what I would do would turn to folks at different universities who I knew were experts or had expertise, who had students who may be interested in serving as interns or doing an externship or whatnot, to help us do some research to figure out how we could, grab whatever information we could to make our points more compelling as we are working to convince folks on the committee that this is the most effective policy and why. So I think those matter. We'd use it to also convince CBO, the Congressional Budget Office, to score a bill in a particular manner to show the cost savings. And again, we would turn to experts who had that research background and that expertise to help us influence. And the same thing with GAO. We would talk to GAO, Government Accountability Office, as they're doing investigations for us, to point them to academics, researchers that we knew, again, may be an expert in whatever area, whether it's in economics or public health, healthcare, you name it. So.
Great. So I wanted to build on the incentives problem point, which I think is really important. I think another challenge in academia is a lot about specialization because you want to have expertise in specific topics. And that's in tension with this political determinants of health framework that is asking people to think about the causes of causes and underlying issues. And in particular, we're, as everyone is probably thinking about, less than 2 weeks from an election. And so I wanted to ask about that tension, but also as it connects to the election and to voting, and what is the role of academia in thinking about promoting the democratic process and having an inclusive and trusted democratic system. So I'll start with Dr. Jones.
I think that's a great question, and it's a really tough one. In some ways, it's kind of at the heart of the existential crisis of being an academic, of trying to walk the line of, on the one hand, being an unbiased researcher coming to my questions with kind of a beginner's mind where I try and, be aware of my preconceived notions to ensure that it's not shaping where my research goes, while at the same time being a human being that has, a pretty well-formed value system at this point, and really has a stake in where my research goes and where, how my research is going to be part of this process. So I think it's a really challenging one. I haven't personally found the answer, and I think the answer is probably different for different people in the academy, which is a really good thing, I think. In terms of how we, as an institution, kind of navigate the political system, as in my view, it's becoming more kind of fanatic in some sense, which is really the opposite of research and engaged policy making, right? Where there is this kind of just unmovable belief that people have in whatever they think the world is. I think we really have to kind of keep at it while at the same time trying to pivot in a way and remaining kind of committed to communicating with people who don't seem on the same page as us. And so I think that's a really important part of kind of remaining in the academy. And I think it's really an important part of our teaching here, especially at our public land-grant university, where we have everybody here with us. And so I really take that part of my job seriously, and I think that's a real place where academics and the academy can make change. And we don't always, speaking of incentives, that's not how, as researchers and academics at an R1 university, that is not the focus of our job. I'll say it quite frankly, the focus of our job is not teaching from an incentives perspective. And I really wish we could start viewing it as a much more important part of our job, because it is our job to be communicating and trying to kind of maintain a commitment to information and truth in our policy-making process.
Yeah, totally agree. I'll just add a plug for interdisciplinarity, because I think that this is not, so the issues that are closest to the answers to the questions that you raised are not the issues that I work on, but directly. But I have colleagues in psychology, in political science, in communication, in sociology, who are working directly on the issues that speak to the heart of this. Things like What is happening with misinformation and disinformation? How is that affecting our political process and our engagement with science as a society? What are the origins of distrust in democracy, distrust in expertise, distrust in government? There are people at this campus and elsewhere who are working directly on those issues, and they are trying to speak as loudly as they can, and they're offering opportunities for those of us who work in other fields to collaborate with them to try to figure out how those issues affect us, how they affect the things we care about. So how does misinformation affect the politics and political conversations around health? How does distrust in science affect our ability to get into those conversations at all? And so I think it's by opening our minds a little bit, and this gets a little bit back to the incentive question, right? But like trying to figure out how do we do the science that we need to do, but also make a little bit of space to move into those interdisciplinary spaces and collaborate with those people who are experts on things that are at the core of scientific impact and democracy.
Right. I have a very long list of other questions, and I think we could talk about these topics for a very long time, but we only have 10 minutes left, so I want to make sure we have time to get to audience questions as well. And so questions either for Professor Dawes or for other panelists.
Professor Dawes, you talked about being optimistic about some of what you're seeing in government right now. Tell us more about what you're optimistic about in government right now.
So when I think about, and you heard me say I see it at all different levels, right? Depending on the state. I'm not quite sure what your state is like here in Ohio. I don't live here, so I can't really relate in that case, but I'll tell you, from my vantage point, I actually live in Nashville, Tennessee, so it's a pretty interesting state at this point when it comes to this agenda. For me, the optimism lies in the fact that we have seen successive administrations at the federal level that had prioritized this health equity agenda. The exception, of course, was with the Trump administration, but we had from Carter to Reagan and Bush and Clinton and Bush and then Obama, of course, all of them had prioritized. They understood the need to address this. They did not put the amount of intervention or the resources needed to do it, but they at least were making steps to address it. So we were on the right path. For me, it's now looking at what we see happening, whether it's New York City or in other medium-sized or smaller cities, where folks are incubating ideas in their public health departments to address this, and they're starting to get the data. They're starting to generate what they believe are interventions that we might be able to scale up, not only in that municipality, but statewide and perhaps regionally and nationally. That's pretty exciting to me. So we didn't have the data before, we're now generating that. At the federal level, I'm pretty excited because Biden became the first president to issue 2 executive orders, basically tackling racial inequities and racism and so forth. That was pretty bold. We'd never had a president do that before, and basically has stated that every cabinet level member is required to come up with a plan to address the issue. Okay? So this is pretty exciting to see what is being created. Will they now have 4 more years through Kamala Harris to implement many of those ideas that they're generating? We will see. But that's what gives me hope. Again, we have at all levels, again, maybe not in Ohio and maybe not in Tennessee, but in other areas we see that and we can build from it. And as the tides change, we might perhaps be able to borrow if we can demonstrate that investment value to the government wherever we are. And that's the beautiful thing, I think, about what we're trying to do, which is to link it and show the cost savings. Because even in my state of Tennessee, I've had great conversations with the health commissioner. He's a major Trump supporter. He and I are probably very different in terms of how we view policy issues, but together on issues of food security, maternal mortality, infant mortality, and beyond, we know that there's synergies. And here he was skeptical when I first moved to Tennessee about a year and a half ago, looked at me with suspicion, what is he gonna bring up now? He had granted me a 15-minute meeting. That meeting turned to an hour and a half because we came with the data, we came with the substance, we drilled down further than I think anybody had done before and presented to him. We care about Tennessee. We want to see Tennessee rise from 45th or 46th nationally to among the top 10 during his tenure. And we know that's what you want, Dr. Alvarado, right? So in that case, we were able to make that case. And I see some headways in that respect. Senator Bill Frist, who was the majority Republican leader, he is in Nashville. He's been working with us to ensure that our communications will resonate with these policymakers in the Deep South. And we're seeing some traction. Now, is there an anti-DEI backlash? Yes. Can we feel the intensity of that opposite? Yes. But where we have been able to find common ground, I'm really excited about that. We may not have that comprehensive or reticulated opportunity, but at least piecemeal, we can still see something. And if we can at least get them not to unravel and show them how existing policies that actually have been moving the needle in the right direction are positively impacting their community, I think we will have done a good thing in that respect, right? It's painful because it's like, gosh, I'm eager to do more, but the political circumstances don't allow for it until perhaps a future election. So that's what makes me optimistic.
Good afternoon. Quick question. You did a really great job of laying out the fact that the inequities we're seeing today are the accrued impact of 300 years of policy, and stating that policy broke it, policy needs to fix it. But we exist today in a world where they want policies that fix 300 years of impact inside a 4-year administration or inside a 5-year R01. How do we get to the point where we can think bigger and longer, because we didn't get here yesterday and we're not going to get out of here tomorrow?
I probably don't have an answer that's going to satisfy you right now, but we know that the system was designed intentionally. It was designed to create the effects that we see today. So I don't know, other than saying that you have every single day is a fight, right, for health equity. And if we allow ourselves to be complacent, then we see the pendulum unraveling those things. We've had long spells where we have elected governments at different levels in this country that have sustained for a while some of those more progressive egalitarian policies. It's really incumbent on us to continue to educate the masses about these things. This is where I was going to actually answer a part of your question earlier about, universities modeling what civil discourse looks like, modeling to the rest of the nation how this can be done internally, how you can incubate these things. I think that's really important. So for me, it is about education, 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 helping folks to connect the dots. Because I'll tell you, even outside of a university, when I'm doing community engagement work, so many members say, oh, I never thought about how voting can mean the difference between life and death in my community. I never thought about that on the front end. And you have to connect those to then the social determinants, right, to the eventual health outcome. We've been able to do that in certain cities, but we have a lot more work. And this is why I'm about harnessing the power of collaboration, interdisciplinary collaboration, as we've been hearing about today. But I don't know how else to do it in terms of sustaining that, other than we've got to educate folks. We got to keep getting folks registered to vote. You got to keep voting. You got to, basically not sleep on these issues, right? Not become complacent, like as has happened throughout different eras in our history when we saw the unraveling. That's what scares me. If we do that, then I think we'll be able to sustain it. Will it be lasting more than maybe 20 years? I don't know. I don't have that gift, but.
Dr. Geller, behind you, we'll squeeze in one more quick question.
Hello, I'm Tahira Jones, a veterinary public student, and I went to HBCU, a historically black college in North Carolina, and I know you mentioned in your book about how gun violence research was shut down by the NRA. Since that HBCUs are predominantly affected by gun violence within the cities, can you talk more about how that socioeconomic barrier will result in less attendance and practice investment within those colleges that are essential to Black and brown communities? Sorry, that was a long question.
And it's a great question. So as somebody who has always been at an HBCU, working on my research and my scholarship, first at Morehouse, now at Meharry, I appreciate what you're saying. And I remember this was an issue that Dr. Satcher felt very strongly about. I haven't studied gun violence like he did and dedicated his career to really addressing those issues. But I will tell you that one of the things he said to me was, Daniel, even though it may not be in your portfolio, it's every one of our issue, right? And he was able to connect for me how gun violence, right, connects to various policies, and dedicated his life to convincing members of Congress. And I'm slipping on the congressman who had put in a rider preventing the CDC to study gun violence research. Does anybody remember that? Yes, what is it? You don't remember the name? Okay. I'll have to look that up. But anyway, what? The Dickey Amendment, thank you, yes, Congressman Dickey. And Satcher was CDC director at the time, and he was trying to figure out how to push back on the misinformation that Congressman Dickey was spearheading within that rider. And he issued an op-ed. And if you know Satcher, I know you all do, he's a very careful person. But he felt the need to say, this is what the evidence shows, right? And how it would affect us. So he does that. And I think 25 years later, Congressman Dickey actually visited with David Satcher and said he regrets that he ever did that, because for 25 years, we didn't have public health research sponsored by the CDC to understand the impact of gun violence on various communities, including the Black community, right? And our HBCUs. So it is an issue. I know that it is something that the leaders of our HBCUs have been working. Oftentimes, it's not necessarily within the institution, it's outside of the institution that some of this has happened. And they're trying their best to figure out how to prevent that. I know Spelman, Morehouse College dealt with that a few years ago. At Meharry, we also had an incident from somebody externally. So it is an issue that folks are trying to address within and also outside with policymakers to get it right.
So I think there are a lot of conversations that we need to continue having. Everyone who registered today is going to get an email with information about future events, so I hope you will come to future events so we can keep these conversations going. You also get a survey for feedback on this event and also any ideas that you might have about future events. So we would love to hear from you. But we are at time, so please join me in thanking Dr. Padamsee, Dr. Jones, and Dr. Dawes.